Good morning, everybody. I'm Howard Chansky. I'm the chair of the University of Washington Department of Orthopedics and Sports Medicine. Welcome to our June Grand Rounds. This will be our last Grand Rounds until September. And a couple of quick announcements just to remind everybody, next Friday, not this Friday, but next Friday is the resident welcoming event. And Dr. Kennedy, is that, or Planette, is that at the Waterfront Activity Center again? Okay. And then remember on June 28th is the resident graduation banquet at Columbia Tower. And a couple of kudos, since we have a relatively long list, I'm just going to announce the names. And Dr. Ellen Goldberg received kudos from Dr. Lampy, who's a pediatric hospitalist at Seattle Children's. Dr. Arthur McDonald received kudos from Irvin Miller, who's one of our plastic hand surgeons. And Nate Benner and Arthur were nominated to attend the annual AOA Resident Leadership Conference in June. So thank you to all of our hardworking residents. And with that, we'll start our formal grand rounds. I want to remind everybody to text within 2 hours of the end of grand rounds so you can receive CME credits. And this morning we are going to have Dr. Nate Benner, one of our R4s, and Dr. Stephen Kennedy, our program director and associate professor and one of our hand surgeons, who are going to discuss the very important topic of competency-based medical education in orthopedic surgery. I know this is something that Dr. Kennedy has thought a lot about, and it's an important element of how we will be training our residents moving forward. So thank you.
Good morning, everyone. My name is Nate Benner. I'm one of the fourth-year residents here at the University of Washington. Today, Dr. Kennedy and I will be talking about enhancing surgical training, implementing competency-based medical education in orthopedic surgery. To clarify, we will be describing the history of and plans for a national shift in orthopedic education based on requirements from organizations that are relevant to our subspecialty. We will also explore our program's plan for implementing those requirements. Dr. Kennedy and I have no disclosures relevant to this topic. Today, I will begin by discussing the principle of adult learning, describe what competency-based medical education is and what entrustable professional activity means, and then finish with some information on assessment. Dr. Kennedy will then take over and discuss the plans moving forward at the national level and for our program. So to begin, in the 1980s, Dr. Malcolm Knowles came up with 5 assumptions about adult learning that are still used in adult learning theory today. The first is the concept that adults engage in self-directed learning. Self-direction and self-evaluation are essential aspects of adult learning. In order to be effective, learners must be able to identify their own needs and take responsibility for their own learning. The second assumption is that adult learners have had a lot of experiences in their lives which become a resource for learning both at the individual level and at the peer level. Adults have a readiness to learn, particularly to learn what they need to know, those things that will be relevant to their own roles, futures, and careers. The fourth concept is that adults are oriented towards their learning. As we shift from postponed application of knowledge to needing to call on that knowledge immediately, our perspective changes, and we become more problem-centered and less subject-centered. And finally, adults have an internal motivation to learn. Job satisfaction, self-esteem, and self-actualization are big motivators. So how do these principles relate to what we're talking about today? Well, we are all responsible for our own adult lifelong learning and for teaching others at different stages of our careers. We are part of a larger medical education community that is focused on adult education, which is governed by national organizations that accredit our programs and license us for practice. Competency-based medical education was introduced over 2 decades ago and has been widely adopted by the medical community, influencing the reform of undergraduate and postgraduate training programs. The 6 ACGME core competencies are patient care, medical knowledge, professionalism, interpersonal and communication skills, practice-based learning and improvement, and systems-based practice. In 2014, milestones were added. Although lists of the core competencies and milestones have been developed to guide training programs, how to focus on the assessment of competence has been less clear. Before diving into details on assessing competence, let's look at where this push began. Before the massive expansion of postgraduate training, Case Western Reserve University's medical school in Cleveland, Ohio, was among the first to recognize, as early as the 1950s, that the content of medical training would be more efficiently delivered if it focused on clinical relevance, next to the systematic, scientific foundation of individual disciplines. With Ralph Tyler as a consultant, this school integrated preclinical courses with clinically relevant objectives to make the transition from theory to practice more natural. This was the first step towards outcomes-based medical education, the precursor to competency-based medical education. So what is competency-based medical education? Medical competence is defined as a learnable, durable, and measurable ability to execute a specific integrative task that is part of the full range of tasks that constitute a medical profession. Competency-based medical education is an approach to preparing physicians for practice that is oriented towards outcomes and/or abilities. These competencies are derived from an analysis of societal and patient needs. It is intended to de-emphasize time-based training and shift towards accountability, flexibility, and learner-centeredness. Some have argued that competencies are theoretical, like professional attitudes and behaviors, interpersonal skills, and thus hard to assess and monitor. Milestones were developed and defined to help with this issue. They describe the steps that a learner takes towards these competencies, allowing for a stepwise measurement of progress. Another recently described way to understand a trainee's progress towards competence is called Entrustable Professional Activity. The Entrustable Professional Activity concept, also called EPA, allows evaluators to make competency-based decisions on the level of supervision required by trainees. Competency-based education targets standardized levels of proficiency to guarantee that all learners have a sufficient level of proficiency at the completion of training. Collectively, the competencies constitute a framework that describes the qualities of a professional. Such a framework provides generalized descriptions to guide learners, their supervisors, and institutions in teaching and assessment. However, these frameworks must translate to the world of medical practice. Entrustable professional activities were conceived to facilitate this translation, addressing the concern that competency frameworks would otherwise be too theoretical to be useful for training and assessment in daily practice. EPAs are independently executable within a time frame, observable and measurable in their process and outcome, and suitable for entrustment decisions. Instead of evaluating a single competency, the goal of an EPA is to evaluate if a trainee can perform a relevant clinical task safely and independently. It allows the assessor to evaluate not only the technical skills, but also the other aspects required for that task. For example, managing a patient with knee arthritis, which would involve being able to assess and diagnose the patient at their first clinical presentation, maximize their non-operative care, perform a knee replacement competently, and follow them up appropriately in the ward and clinic. An entrustable professional activity combines all the tasks, knowledge, and skills that are required to function independently on this core activity. This is argued to allow the shift from a checkbox approach to assessment that many have found frustrating in their evaluation. Here is a table by the AAMC describing the benefits and disadvantages of both entrustable professional activities and competencies. So what do EPAs look like in practice? This table shows illustrative entrustable professional activities across several subspecialties. In this example, they describe that performing an appendectomy requires medical knowledge and patient care, while management of a patient with a chronic disease requires patient care, interpersonal skills and communication, professionalism, and systems-based practice. Here's an example of how one might assess entrustable professional activity, like in a patient with knee arthritis. Level 1 would be somebody who is able to do observation but no execution, even with direct supervision. And then a level 5 would be supervision provided by the trainee to a more junior colleague. In 2016, Dwyer et al. Tried to study how we might use these entrustable professional activities to assess trainees in orthopedics. They used simulation to evaluate the performance of orthopedic residents in ankle fracture, hip fracture, and total knee arthroplasty entrustable professional activities. This is a breakdown of the entrustable professional activities and the components assessed. Each was 40 minutes long with 3 components: preoperative management of a patient, which included history taking, examination, image interpretation, performance of a technical procedure on a sawbones model, and postoperative management of a patient, postoperative orders, management of complications. Residents were assessed by 6 faculty members who used checklists, an overall global rating scale, as well as a previously validated global rating scale for the technical procedure component of each activity. 9 PGY1 and 9 PGY4 residents at one institution participated in the simulation. Examiners were instructed to deem a resident as competent if the resident performed to the level of a qualified orthopedic surgeon and was able to perform the procedure independently without supervision. They sought evidence of a difference in performance between PGY1 and PGY4 residents on the overall global rating scale for each station of each entrustable professional activity. Overall, they concluded that the simulated activity can be helpful in determining which residents can perform certain entrustable professional activities in the simulated setting, and importantly, identification of those residents who require further training or remediation to achieve a minimal level of competency. As you can see from the results here, the PGY4 residents perform better than the PGY1 residents, and the distribution makes sense, such that most PGY1 residents can demonstrate competence on the preoperative management of a hip fracture patient, but not the technical procedure yet. Future work is needed to see if this would correlate to resident performance in the clinical setting, but I think it highlights that simulation can be a good way to understand a trainee's progress. Okay, at this point, we've heard a lot about adult education, competency-based medical education, and entrustable professional activity. Let's shift towards the concept of assessment. Assessment and feedback from faculty are perhaps the most important factors to your development as a surgeon. When thinking about assessments, they can be lumped into 2 main categories: formative and summative. Formative feedback is provided in real time, similar to coaching, for example, during or at the end of an operative procedure or at the end of an office day, while summative feedback is provided after the learning, like at the end of a rotation, and often used as the final assessment, which is generally high stakes. Historically, clinical assessment has been one of the more complicated aspects of training programs, with many attempts at improving high-quality feedback. In 1990, George Miller outlined a model for the assessment of clinical competency. He argued that the traditional assessment of medical students relied too much on their knowledge and not enough on assessing how they would behave in a real-life consultation or practice. This helped to shift the focus from more solely medical knowledge tested by written exams to that of clinical competency with a larger focus on the end product of training. Originally, medical schools devised their own objectives and courses, but increasingly, outside accreditation and certification bodies have taken over that role to help define what needs to be learned for a successful practice and to make a national framework that focuses on the ideal image at the end stage of training. This framework helps to guide both learners and educators, allowing the educational goals to drive the design of the curriculum, the learning of individuals, and their assessment with the end goal in mind. I will briefly describe some basic frameworks of assessment which can be used when designing a curriculum. Analytical frameworks are outcomes-based. They divide the competence into domains that facilitate measurement, for example, knowledge, skills, and attitudes. We have methods to evaluate medical knowledge, separated from a skill needed to apply it, separated from, say, how that knowledge is incorporated into obtaining informed consent. Analytical frameworks tend to create very long and detailed lists of objectives. Synthetic frameworks are integrative and less measurement-oriented. The main question they ask is, what activity or task can be entrusted to a trainee once sufficient competence has been reached? A trainee may be able to technically perform a specific activity, such as splinting an ankle fracture, with consistency and reliability, but would not be entrusted to do so unsupervised unless and until this entrustable professional activity is mastered in a broad and integrative sense, embracing the communication skills, professional attitude, and situational overview that allows patient-safe management in various situations. And finally, in a developmental framework, the learner progresses stepwise up a ladder towards independence, essentially a milestone-based framework. This is a table summarizing the 3 frameworks we have just covered, which includes definitions, assumptions, advantages, and limitations. There is no perfect framework for assessment of competence. At the starting point of the ACGME model, it was analytic. The developmental aspect was not intrinsic, but with the implementation of milestones, it has become a hybrid framework. At present, national boards mainly rely on written and oral examinations to assess competence of residents, essentially a summative assessment. However, these examinations do not assess trainees' ability to perform required procedures. Assessing actual performance is the responsibility of residency programs. With that in mind, residency programs need a validated tool to assess residents reliably. So in 2012, a group out of Toronto came up with the Ottawa Surgical Competency Operating Room Evaluation, or the O score, a tool to assess surgical competence. This validated tool became the basis for the evaluations you see in the ABOS KSB assessments that are sent from residents to faculty. This allows the program and the ABOS to understand competence throughout a resident's training. In summary, there has been a shift in graduate medical education towards a competency-based model. Evaluating entrustable professional activities may offer a more holistic way to assess trainees. And in general, there is a trend towards emphasizing formative assessment during residency. Now I'll turn it over to Dr. Kennedy to further this discussion.
Thank you, Dr. Banner, for that great review. My name is Stephen Kennedy, and I'm the Residency Program Director here at UW. And I want to share a little bit about how we are implementing CBME in our department. As June approaches, we are planning to welcome 8 new interns. They'll don their new white coats with this departmental patch, go through orientation, and prepare for the next 5 years. And at the end of the month, we'll celebrate our graduating chief residents. It's incredible to see their growth from interns to independent surgeons over the course of their residency. The practice of orthopedic surgery is a great responsibility. Lapses in knowledge, skills, and professional behavior can result in complications, malpractice suits, and loss of institutional privileges or licensure. Preventing these lapses has great benefits to the public, our profession, and to the graduates themselves. And there are multiple organizations that are relevant to our residency with a shared mission to serve the public and/or our profession. UW Medicine has a mission to improve the health of the public, and UW GME, or Graduate Medical Education, supports that mission through a supportive culture of learning and safety across residency and fellowship programs. The ACGME is the accreditation body for the residency. If we lose accreditation, the program ceases to exist. The ABOS is our board certification organization and are relevant for certification of orthopedic surgeons over the course of their careers. The AOS is a membership organization for orthopedic surgeons. They administer the OITE that residents take every year. They also have a number of educational resources, grants, and opportunities for networking, outreach, and leadership. And the AOA is our leadership organization, also our oldest orthopedic organization, founded in 1887. They engage the orthopedic community to develop leaders, strategies, and resources. 2 of our PGY4 residents each year are nominated to their resident leadership forum. Dr. Benner and Dr. McDowell will be going this year. Multiple of our faculty have also been elected to AOA. They also support the Council of Orthopedic Residency Directors, or CORD, which is an organization of all the orthopedic residency directors across the US, as well as many from Canada. So each of these organizations has an important voice in directing how we train residents in our department. The 2 most important national organizations related to competency and orthopedic residency are the ACGME and the ABOS. Both are organizations of self-regulation, of physician self-regulation, with the purpose of protecting the public. That's the most important thing for them, to protect the public. Together, they're bringing major changes in how we assess and report on our residents. As was mentioned, in the 1990s, accrediting organizations in Canada and the US recognized the need to apply an analytic framework to the competence of a physician as a medical expert. For the ACGME, this was the 6 core competencies that we continue to use today. However, it was recognized that further specificity was going to be needed for individual specialties, especially in patient care and medical knowledge. So in the 2000s, the ACGME Orthopedic Review Committee and other stakeholders began working towards a list of orthopedic surgery milestones. The initial iteration of the orthopedic milestones was implemented in 2013. It included 41 milestones, most of which were paired patient care and medical knowledge milestones for 16 different conditions or diagnoses. Although there were benefits to setting expectations for different diagnoses and procedures, there were also parts of this that were quite burdensome. There were too many milestones. They were too procedure specific. They were inconsistent across rotations. There was a sort of a lack of visibility or shared mental model for trainees and faculty. And the number of milestones was burdensome for faculty and for clinical competency committees. So work continued, and feedback and revisions from ACGME and the other stakeholders that were mentioned. And the Orthopedic Milestones 2.0 was introduced in 2021, and that's currently what we continue to use. And so instead of having those the large number of individual milestones, patient care is broken down into 7 different categories of surgery, so fractures and dislocations, soft tissue pathology, and so forth, as well as the evaluation and management of adults and pediatrics. And then each of the other categories has 2 or 3 questions associated with it. So here's an example patient care milestone for operative management of fractures and dislocations. It's important to note that level 1 is a novice, level 4 is a graduation goal, but not necessarily a graduation requirement. And level 5 is designed to represent an expert resident whose achievements in a subcompetency are greater than the expectation. Milestones are primarily formative as opposed to being summative. And so making decisions about readiness for graduation and unsupervised practice is ultimately the purview of the program director, and that's informed by the clinical competency committee. Milestones should not be a sole assessment in any high stakes decisions in terms of determination of eligibility for certification or credentialing. And the ACGME continues to evaluate and perform research on these milestones. I was involved in an interview for a study just last week. So each of the vertical columns lists the expectations for the different levels of competency. And then there's horizontal sections. So there's 3 different parts for each one: the pre-op planning, the intraoperative execution of the procedure, and then post-operative planning or readiness for complications. So if we were to take this example, if the resident achieves all of the components of a vertical column, then they have at least that level of proficiency. If they have 1 or 2 and then in the next level up, but not all of them, then they go up half a level as opposed to being a full level. So in this example, the resident is rated as a 2.5 because they've got 1 part of the level 3, but not all of them. End of rotation feedback has limitations. It may not reflect the progression with specific procedures. Delayed written feedback is less specific. Verbal feedback can be misunderstood or forgotten. So very early on, actually in the first year that the milestones were developed, our department developed an early milestone tracking and residency competency system. This was led by Dr. Hannell, Aaron Chirones, and 2 of our residents, Dane Mickelson and Kenny Gundel. Kenny Gundel is now the program director at OHSU. It's a trainee-driven mobile digital platform to facilitate real-time resident feedback. It involves tracking of ACGME milestones, data analytics, and a reporting system. And this continues to be used by multiple cardiothoracic programs across the country. However, for orthopedic programs, the American Board of Orthopedic Surgery wanted a comprehensive solution with a residency to retirement roadmap. And they recognized that validated tools would be critical. They needed to maximize the collaboration between different organizations that I mentioned. They wanted to avoid redundancy and increase sharing of data. And they wanted to reduce administrative burden, both for the resident and also for programs. So the Knowledge, Skills, and Behavior KSB program was developed to enhance assessment, feedback, and training. And each of these critical areas is evaluated with a validated instrument. So for knowledge, the American Academy and the ABOS now collaborate through a linking study. So by having residents take the OITE with a subset of questions that's hidden from them that are actually from the Part 1 exam, then statistically the exams can be analyzed and we can determine a raw score percentage that would predict passing the Part 1 board. So for example, this year residents that scored greater than 63% raw score on Part 1 are likely to pass the Part 1 of the boards. If they are not reaching that level, then it can be a trigger to help with remediation. In terms of surgical skills and professional behavior, historically, the ACGME required case logs, and the number of cases was used to inform appropriate case experience for the residency program. And different institutions had different methods for assessing professionalism through a variety of different applications and reporting schemes. The ACGME and the ABUS now have an integrated KSB Plus app that helps gather information on both of these areas. So I'm just going to explain a little bit more about how these surgical skills assessments are done, how the tool works. So for surgical skills, the resident requests the assessment, the attending completes the assessment, and then the resident receives feedback in real time. They use the KSB Plus app to log all of their cases. It can be done either through a smartphone-enabled app, or it can be done through a web portal. And the integrated platform allows them to do a checkbox that will immediately send a request for feedback in the same place to the faculty member that they did the case with. Residents initiate the skills assessments. It needs to be done within 48 hours of the surgery happening, and they can only do one evaluation per day for the same procedure type. The faculty respond through any web-enabled device. It's been smartphone optimized. The evaluator receives a text or email with a link based on their preferences. There's no login or setup needed, but it must be completed within 72 hours, and there's a reminder within 24 hours. As was mentioned, the basis for this validation is the Ottawa Surgical Competency Operating Room Evaluation Score, the O score. Under this model, there are 8 facets of a surgical procedure, from the pre-procedure plan through the post-procedure plan, as well as efficiency and flow and communication. Each of these facets is graded on a 5-point scale, from a level 1, where the supervising physician needs to be completely hands-on with guidance, up to a complete independence in level 5. There's also a P score, which is a global assessment of overall performance rather than going through each subsection. And in a study of 16 orthopedic surgery programs with 294 residents and over 1,100 evaluations in each group, both the O score and the P score showed construct validity for differentiating different levels of autonomy by year in training. And over 70% of faculty were confident that either score allowed them to distinguish a resident who can perform the surgery independently from one who needs more training. And so the ABOS decided to bring those 2 assessments together, and that's what the ABOS KSB assessment is today. When you're a faculty member who's filling out this surgical skills assessment, the information can be found online if you want to read more about it, but each of the questions will have a description of the definitions within the form. And at the end of it, there's a text section, and this is probably the most helpful for the actual formative development of the resident. And you can either type it in on your keyboard, or you can use the microphone dictation part that most devices have. Milestone assessment is based on the competency expected of independence. So this is a bit of a frame shift in terms of how we think about things. For knowledge with the OID linking study, it's really about readiness to pass part 1. And it's all about the raw score. For skills assessments, it's readiness for procedure independence. So a PGY1 can still be very good for their level despite not being competent for independent practice, but ultimately the goal remains to achieve independent practice. Professional behavior is similar but slightly different. So for professional behavior, there's 2 types of professional behavior assessments. There's one at the end of each rotation. That's where the resident requests the assessment, the faculty completes the assessment, and then the program director and the program coordinator receive the feedback. And there's also a yearly 360 evaluation. In this case, the ABOS sends the assessment, not the resident, and it gets sent to multiple people listed by the department as appropriate people to evaluate the residents. They complete the evaluation, and then that also goes to the program director and the program coordinator. So different than the skills assessments, professional behavior assessments go directly to the program director, and they're based on ethical behavior, communication, interaction, reliability, and self-assessment. And this has been validated. Also, you can review this study by Armstrong et al. In JBJS. It's 5 domain tool. As we mentioned, there's an end of rotation and a 360 component. They identified 2.4% of residents have a low score behavior, so it's not a very frequent issue. But what they found was that there was strong correlation between what the assessment identified and what some program directors were already aware of were potential areas for improvement in terms of professional behavior. There was concordance for over 81%. The residents benefit from this with a resident dashboard, and it allows them to follow their progress. So there's information about progress in each area, including their progression in the OITE. Once they reach a level of score that correlates with passing part 1, then there'll be a change in color in terms of the column, in terms of their graphing. There's also surgical skills assessments and other ratings. There's also a number of other resources that they can use. From a program perspective, we get multiple dashboards and reports. There are the ABOS KSB milestones reports, and we can look at these in different ways with different amounts of information. We can get the text that gets entered. We can get all of the numbers for individual residents, and we can also get in tabulated format. We can also get program participation reports, so we can see which residents are on track to get to getting what we recommend in terms of their frequency of their surgical skills assessments and their professional assessments. And we can also see how faculty are performing in terms of what percentage of their requests are being completed and the time frame that they're being completed in. You can get more information at the ABOS KSB website. You can also reach out to me over email if you have any questions about this. The most important thing that I want to communicate is the mandatory requirements. So as I mentioned, both of these organizations are moving forward with increasing the mandatory requirements for these changes in competency-based medical education. So beginning academic year 2025-2026, so on July 1st, we need to have full 100% participation in this for our residents to be able to take part 1. The requirements are that every resident takes at least 3 OITE examinations during PGY1 to PGY5. Our expectation is that residents take this every year, so that is not really an issue. For surgical skills, they need to do at least 80 assessments per year from PGY2 to PGY5. And in PGY1, they need to do it at least 12 assessments. For professional behavior, they should do it at the end of every rotation, but they need to have at least 6 completed per year in PGY2 to PGY5, and they need to do at least 3 when they're in PGY1. And this responsibility, ultimately, as opposed to being an accreditation issue for the program, this is an issue for the resident individual being able to take part 1 exam and to achieve board certification. So in terms of implications for our program, residents without adequate assessments will not be able to sit for part 1 exam. We need to more closely track completion of case logs, surgical skills assessments, and professional behavior assessments, as well as continuing to monitor MedHub evaluations. And we'll need to reduce redundancy as the participation increases. So we've already replaced the MedHub 360 with a KSB Plus 360, and we will replace the MedHub evaluation of professionalism as soon as we're able based on participation with the KSB program. In summary, the validated tools and curricula are needed to prepare residents for independent practice. The CBME and ABOS are increasing mandatory requirements, and meeting these requirements is going to be a collective effort on all of our parts. And competency-based medical education will impact our curriculum, rotation scheduling, and clinical care, and we will need to adapt over time. Nate and I wanted to leave some time for questions and discussion. And so if anybody has any questions, we'd be happy to answer them.
There's still 71 people on the call, and so please feel free to speak up or raise your virtual hand or um, put something in the chat box, although I don't see that on my, oh, there it is.
Yeah, this is Lisa Tatesman. So that was an excellent review. Nate and Steve, thank you so much for doing that. I guess my question is, what do you do? What might you see as some of the opportunities and challenges? How do you think this might help us, or what do you think may be some of the challenges?
I think some of the challenges with the competency-based education, the kind of the bigger picture thing, is that if we're going to be attaining all of these assessments in terms of where people are, and we can kind of identify where people's strengths and weaknesses are, we need to be thinking about what we're going to do to be able to deal with that. And so the advantage is that we can try to individualize what residents do, but the challenge with that is that it doesn't easily fit into what much of our scheduling is based on time, and there's clinical care components of this, and so that flexibility could potentially have, that requires some greater support in terms of managing the clinical care. So we'll just kind of have to figure out how that works. I think the other thing is, this concept of entrustable professional activities, thinking about how we decide when residents are ready to take on some of these responsibilities, and how we can show to external organizations that we deem that they are ready. So the UW GME has already has also already required each department to come up with supervision guidelines, and those are going to be continually improved. And we're going to need to be able to document how we prepared people for example, to handle an overnight emergency in the emergency department. How do we know that the residents at a 1 or a 2 or a 3 level have been adequately prepared to be able to manage those issues? So there's even things within residency, even before the end of residency, that we need to be thinking about.
There is a question from Dr. Yindao, who is asking what you see as the strengths of our program and the weaknesses, and we will not put Dr. Benner on the spot with that question. We'll put Dr. Kennedy on the spot.
Well, I think the strengths are that we were early adopters of considering these things with eMetrics. We have been thinking about these competency-based issues as the milestones have developed. I think in terms of other, and I think that we have some excellent surgical simulation resources. We've got a large university system with potential for collaboration with other departments, so we can improve that. The WISH resources and the interest in doing surgical simulation research is great. And we also are well funded in terms of our access to cadavers, for example, if we want residents to be able to get greater experience with surgical skills. I think the challenge is that we rely on our residents quite a bit for our clinical care. Residents are an important part of serving the mission of UW to improve the health of the public. And so we need to be thinking about when a resident needs remediation, when a resident needs to improve in certain areas, how can we help adjust things to make that happen without putting too much stress on our system, on our patient care, and other residents who are also trying to maintain their maximal learning. So I think those are the things that immediately come to my mind.
That's a great answer. I would only add that I think the biggest strengths of our program are the residents and the faculty, and it's something we can build off of. And Dr. Kennedy and Dr. Benner, do you think this new evaluation system will eventually lead us to have even a more nuanced or better understanding of the strengths and weaknesses of our training program and the department?
Yes, I think that it's going to, I think it's going to challenge us, but if it doesn't challenge us, it won't change us. This is going to be very interesting. I think there'll be quite a bit of information that could potentially come out of these skills assessments, and we could get a very detailed look into what the individual challenges of each resident are experiencing. So I think there's going to be a lot of advantages with that.
Maybe some service-specific information or specialty, subspecialty specific information that we can use.
Yeah, absolutely. I think, oh, it's just another question there.
I don't see any. Does anybody else want to speak up with any other questions or concerns about the system, the new system?
The only other thing that I would add, while anybody else is having any questions or concerns, is that some of the things that we didn't get into are this concept of active learning in the classroom also. Dr. Benner has been very active with this and has been very enthusiastic about application of adult learning principles to all the aspects of our program, and has implemented or continued to increase the amount of active learning activities that we do in our Monday morning conference. And so looking forward to doing more of that for those of you that are participating in Monday morning conference. We're going to be heading towards more adult learning principles, so having more discussion, problem-based learning principles, flipped classroom concepts. So kind of the more that residents prepare and use the time to use whatever resources that they feel most helpful to prepare for a session, and then to apply that knowledge that they've gained to actually real world or simulated real world problems, is going to be the best use of that very valuable time when people are in learning sessions away from their clinical care duties.
Well, thank you, Dr. Benner and oh, is there a question?
Well, it's Lisa Tatesman, and again, if we do have a few extra minutes, can I just make one more just comment, and I will actually say this with my my ABOS hat on.
Sure. And then I just want to add, after that, Dr. Greenwald has a question.
Great. I just thank you, and that was a great overview of the requirements. There's going to be a lot more to come, especially being presented at court this coming meeting. But I just wanted to be clear about the ABOS requirement. So maybe we don't do another one just focused on that. It basically is coming. So for anybody who is going to be, like, every resident starting the next academic year will have to participate. I just want to clarify there is no level. So it's not like if somebody doesn't get a 4 or a 5, they cannot sit for their board. But it will be a hard stop for sitting for part 1 with remediation options. So I really encourage people to know that it's real and there will be some teeth to it. And we thank the faculty in advance. These really take about 30 seconds to do on your phone. And also feel free to reach out to me if you have any questions or concerns about it as well, since Steve is just delivering and really delivering the information and really actively helping us participate. Hopefully some objective measures on classically subjective behaviors will be proved to be useful for residents for feedback and useful for the program. So thank you.
Doug Hannell here. Steve, if I perform poorly on my OIT exam for 5 years, can I take part 1?
These are important questions that we are going to be facing. We will be able to advise the resident of their likelihood to pass, and unless something significantly changes, then that might be a situation where the clinical competency committee or the program director may decide that they're not ready to take the examination, and they may need more time to remediate to get back on track. So these are the critical questions that are going to come out of competency-based education. I see that Dr. Greenwald has also asked about how this might affect personal health or social demands that may take residents away from training or extended periods of time, like pregnancy, et cetera. This is not going to replace. Some people have talked about, well, like if it's all competency-based, are we going to, reduce the amount of time that residents spend in residency? That has been a discussion ever since this discussion of competency-based education started. And the answer right now is no, that nobody's pushing for a reduction in the amount of time of residency, but some residents may need more time to complete residency. So there could be additional time. And I think we need to be thoughtful about how we can best address that. I mean, what are your thoughts, Dr. Hanel?
Well, my thoughts are this is going to create a huge conundrum. I mean, that there's a number of issues that we will have to discuss, and one of them is what if, and whose responsibility is it to get a resident to competency? How do we incorporate that into a residency training or a postgraduate? So is there a PGY 6 or 7 or 8? And when is it truly legal to say that we are done trying to educate a resident? This is a great way to monitor residents who are performing well. Is it going to be more than an identification tool for residents that are performing poorly?
Yeah, Dr. Handel, this is Howard, and I would add to that I know some of the faculty and the residents have heard me say probably many times. My sense is there's at least 40% more to learn now as a resident than I had to learn 30 years ago, and yet the length of residency training hasn't changed in that time, and it's really difficult for me to understand how I would have achieved whatever confidence I achieved in those 5 years as a resident, graduating in 1992. How would I do that now with so much more to learn? And so I think the issue of PGY 6 in particular is a really good question. And should that be mandatory for orthopedic residencies now?
Howard, it's Suzanne Yondo.
Yep.
I think for the residents, you guys need to understand that this achievement on the OITE is your responsibility. And it is a tool that is going to help you understand whether or not you can take that type of test, pass at a level that the board will require for your written boards. And so if you're performing poorly on your OITE, you need to wake up and really say, what does it take for me to achieve a higher score? Sure, it's a test, and we all hate these written tests that test our knowledge. We don't feel many times that they represent what we know. But the reality is you have to be able to answer the knowledge-based material on those types of tests to prove that you are competent to take care of patients. And so instead of thinking of this as a hurdle, I would think of this as feedback to you to know whether you're going to pass that test. And if you're not doing well, let us know. And I think our program can help develop remediation within the program for someone who isn't a good test taker or has got knowledge gaps. That's where our responsibility comes in. But I think it's your responsibility not to say, this is a hurdle and it's not my fault and I can't, take personal responsibility. This test is to help you know if you're going to pass. So that's how I would see it. And that's what I was told by my chair when I was a resident. If you don't do well on that test, you're not going to pass. And so you need to do whatever it takes to be able to take that type of test and score well. Oral boards, different. We're going to probe you as your professionalism and how you actually operate and take care of patients in a different modality. And that's a different set of skills to demonstrate. But the written test is just really a challenge for many of us. And you're going to have to learn how to take those tests, and you're going to have to learn how to do well. And I know you guys all have the ability, or you wouldn't be in the residency.
Thank you, Dr. Yando. I think the other thing that I would add, I see Dr. Manner's comment about that is related in terms of how do we know what this means in terms of our outcomes later. And, you know, sometimes people can see it as just a test, but we know from studies in other specialties that performance on the part one and also part two are some of the strongest predictors of inpatient morbidity and mortality when people go into practice. And challenges in these different areas are associated with, you know, major stress for the graduate. They can lose their licensure. They can have other challenges, and their patients can suffer as well. So these do have meaningful changes, and there's some stronger evidence for the test taking at this point than some of the milestone information. So,
and Dr. Kennedy, I want to get to Dr. Manner's specific question, because I think it's something we're probably all wondering. And I interpret that question as asking, with these changes that are coming, that there seems to be some evidence to support them. How are we going to know that at the end of a 5-year residency that our residents, as Paul says, that are graduating in 2028 are better prepared, or at least as well prepared as residents that were evaluated using the old system, graduating, say, 10 years prior to that?
I think at the time of graduation, there's going to be more emphasis on validating tools like objective structured clinical exams like OSCEs or the supervised practice of specific entrustable professional activities, or what some people call everyday professional activities, as people approach graduation. Other than that, it's, you know, we would be looking at kind of epidemiological data.
Yeah.
I don't know what Paul thinks or what Dr. Manners thinks.
Well, I was going to add, I think it's really challenging to do that because we don't have the data, the granular data to really know how we've been training our residents in the past. I think we all have a gut feeling, those of us who have been doing this for a while, but you know, that's anecdotal. So I think it's a great question, Dr. Manner.
And to go back to Dr. Yando's point about, you know, resources, and, you know, so with and also Dr. Handel's question about someone who's performing poorly on the OIT for 5 years, we want to avoid that as much as possible. Some people do have challenges with test taking, and sometimes it's challenging, you know, to be a test taker while being an orthopedic resident. It's different than being a medical student or an undergraduate. And so we have another great resource here is the GME Wellness, and they actually provide they can provide people with learning specialists, some free visits with a learning specialist, so it can take a really good look at what people's challenges are and help them with a study schedule that works better for the way that they learn. So it's kind of a more individualization of teaching and learning.
And then Dr. Hernandez asked the question that I would expand. He's asking, is there an ability to reward residents who score in certain OITE percentiles? And I would add to that, is there a philosophy of learning in terms of the efficacy of rewarding learners for performance like that?
I think it's a good question. I think it is a philosophical question. Dr. Benner started the presentation off about talking about adult learning principles, and what we see is that residents have tremendous intrinsic interest in being good at their job and being prepared for their profession, and sometimes it's just most important to understand why that is helpful. I think trying to create extrinsic rewards, small bonuses to try to achieve certain levels can sort of bring it from an extrinsic to an extrinsic thing that really is, I think, less meaningful. And so philosophically, I have some issues with that kind of concept, but I think it's open obviously different people are gonna have different opinions on that.
I can't quote the exact reference, but at some point I had read a study that came out of like the Department of Education at the University of Michigan looking at what determined success in college. And it's been a long time, but the take-home message I got from that study was that it was really love of learning and not learning, seeing it as a means to an end, but just an internal compass that drove students to want to learn, that got great satisfaction out of that. So somewhat related to Dr. Hernandez's question, and I think in line with what Dr. Kennedy said. We do have a few more minutes. If there are no more questions, I want to thank Dr. Kennedy and Dr. Benner. That was a great discussion, and it's our future that we need to figure out how to incorporate into our residency. And I just want to remind everybody, it's not fair to expect people to chase everybody down to fill these evaluations in. And there is an element of that I know that is currently being done. And in the future, it's really going to hurt the residents if we don't get these KSB evaluations done. So please make that a priority when it pops up either in your text or your email, or perhaps Angela can set it up so you get both. All righty. Thank you, everybody. Yeah, that was fun. Have a great day.
Thank you.